Thank you, sir.
Sir, we are now live. With all your permission, I am starting this session.
Sure.
Good afternoon, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Ramesh Roop Rai, sir. Sir has done MBBS, MD, DM in gastroenterology, and director at Rai Specialty Care and Research Center, Jaipur. Today, sir is going to discuss on a topic management of gastroesophageal reflux disease. Let me tell you overview of the topic. The passage of the gastric content into the esophagus, gastroesophageal reflux is a normal physiological process. However, gastroesophageal reflux becomes a disease when it either causes macroscopic damage to the esophagus or causes symptoms that management of GERD patient is based on the frequency and severity of symptoms and the presence of erosive ecophytes and Barrett esophagus. To learn more about this topic, I would like to invite Sir Dr. Ramesh Rai, sir. Sir, over to you. Kindly proceed from here.
Good evening, dear friends. Thank you very much for your kind introduction and introduction to the subject. As has just been mentioned, it's a normal physiological thing to that the acid goes into the esophagus and it is thrown back into the uh, stomach and no symptoms occur. But when there is a break in the continuity of the mucosal lining, or the gastroesophageal junction becomes loose, or the tightness of the slings of the uh, slings become less over here, then it is called as gastroesophageal reflux. And it becomes disease when you find that the gastric contents are going into the esophagus and causing troublesome symptoms by irritating the lining of the esophagus. It's a wide spectrum of the disease which is there. And defining gastroesophageal reflux disease is a difficult thing, and the Montreal Consensus reported that condition that develops when the reflux of stomach content causes troublesome symptoms or complications, then it is called as gastroesophageal reflux disease. So we have to focus on the word troublesome symptoms, which is very, very important. So, newer definition which has just been coined from ACG guidelines from 2021, it shows that single unifying definition of GVRD is difficult. GRD is a condition in which the reflux of gastric contents into the esophagus results in symptoms and complications, the old Montreal classification. But they have just added one more thing, that it can be objectively defined by the presence of characteristic mucosal injury seen at endoscopy, or sometimes when the endoscopy is negative and the mucosal lining appears normal, abnormal esophageal exposure, acid exposure demonstrated on a reflux monitoring study. We'll talk about it little later. So if you can document it, also it is a important diagnostic tool. But can you do that? Everybody has got heartburn. दिल जलता है दूसरों की प्रगति देखकर, दूसरों को अच्छा करते देखकर। और यही दिल के जलने की जो बात है, ये शायरों पर भी शामिल होती है। इट इज ऑल्सो देयर विद द लवर्स, दैट दिल जलता है किसी और को देखकर। सो ऐसा ही दिल जलता है इन द गैस्ट्रोएसोफेजियल रिफ्लेक्स। सो हाउ कैन जीआरडी कैन बी डायग्नोस्ड? It is not essential that you do some test and then decide it. Only on the basis of classical symptoms of heartburn and regurgitation causing discomfort are sufficient to make a presumptive diagnosis. What we the word is presumptive diagnosis. No further test is required if you want to do this. So does one need some test? Yes, sometimes it is a therapeutic and a diagnostic test, what we often call it as empirical trial of PPI. This is the simplest method of diagnosis. Patients with classical GERD symptoms are given omeprazole 20 milligrams twice a day, half an hour to 1 hour before the meals for 8 weeks. Improvement occurs in about 60 to 70%. And this test is having sensitivity of 68 to 73%, but specificity is poor. So some may respond, but still do not have what we call as the, but it is highly suggestive of GERD. A negative does not rule out the GERD. No further testing is required to confirm this diagnosis. So we have to rely on the symptoms, and the symptoms are important. Then do you everybody patient needs endoscopy? No, those who are not responsive to PPI therapy, the empirical test will need a testing, or patient with alarm symptoms. What are these alarm symptoms? If there is development of anemia, dysphagia, hematemesis, melena, unintentional weight loss, these group of patients should be investigated with the endoscopy early. And what are the endoscopic findings? On the white light endoscopy, gastroesophageal reflux disease, as has been mentioned earlier, that there are some erosions or ulcers in the esophagus. But this occurs only in 30 to 40% of patients only. But other way, the mucosa appears normal. So in 60 to 70% of the cases, normal mucosa is there. This is called as non-erosive reflux disease. So it is important to understand erosive reflux disease or non-erosive reflux disease. Non-erosive are more. So even if the endoscopy is normal and the patient says, oh, I am having normal, so why should I suffer from these symptoms? So erosive mucosal disease is classified into four groups. It is called as grade A when you have only one or two breaks in the mucosa at the G junction. They are less than five, two centimeters. That is very small. When it becomes more number of breaks which are there, one a longitudinal break more than 5 centimeters, two, three, five ulcers are there, then you call it as grade B. Grade C is that three-fourth of the circumference is having the ulcerations. And grade 4 is all areas are having ulcerations. And the one which is called as the Barrett's esophagus, you have the gastric mucosa coming and lining the esophagus. And that is a precancerous condition, and we have to understand. And if it is not there and mucosa appears bilkul normal, then it is called as non-erosive reflux disease. So if the endoscopy is normal and doctors say, congratulations, the endoscopy was negative, everything is perfect, all right. But the patient is having symptoms. If his symptoms are bothering him, he says, I'm worried about and I'm concerned. I cannot bend over after after the meals. I cannot eat or drink well. I like my whole life is affected. The quality of life goes down. Heartburn disturbs my sleep. So this patient is not satisfied. So we have to take care, even if the patient is having and saying that I don't have endoscopy positivity. So whenever you have a patient with symptoms suggestive of GERD, 8 weeks, one before the meal, daily PPI should be done. Given a complete relief if GERD is likely is there, so discontinue the treatment after 8 weeks. If the symptoms recur, it confirms that the patient is having GERD. If there is incomplete relief, if there is incomplete relief, the endoscopy should be performed after stopping the treatment for 2 to 4 weeks. And if there is a LA grade B, C, and D, and Barrett's esophagus is present, it confirms the GERD. But if there is normal EGD, LA grade 1 only, that means only one or two breaks, reflux monitoring of therapy should be performed. If it is normal, consider that there is a other cause which is there. And what are those things? Which is called as reflux hypersensitivity. That means the patient has symptoms, but normal pH is steady. It is called as reflux hypersensitivity. ऐसा है जैसे कोई किसी के तो सुई चुभा दो, ये दिखाओ, तो भी वो चिल्लाता है, और दूसरे होते हैं जिनमें सुई चुभा दो, उनको भी कुछ symptoms नहीं होते. So if there is hypersensitivity, as it occurs in the IBS, the same way occurs in this. And if it is not there, that means their symptoms are not there and the pH reflux is not there. It is called as functional heartburn. So how should we manage? Lifestyle modification is one of the most important. They are specifically helpful in mild to with intermittent symptoms, not in all patients with severe disease. Avoidance of or tailor-made amount of food should be taken. Don't gorge yourself. इतना मत खाओ कि पेट फूल के तुम्बा हो जाए. इतना कम खाओ जिससे कि आपके symptoms आगे नहीं आए. And avoid those food which are irritating and precipitating the symptoms. And that should be avoided or reduced. Citrus fruit or drinks, fried fatty meals, tomato, spicy food, tea and coffee, aerated drinks and cola. And the most important thing is alcohol should be avoided. No steady shows clinical improvement in GERD symptoms and complications with avoidance. That means clinical symptoms may improve, but you cannot avoid the complications. You cannot treat the disease. What are these lifestyle modification? Avoidance of late night meals. Most of us are busy doctors, and when we go home it is 10 o'clock, and at that time what happens that we are so tired, we just take our meals and go to bed, see the TV for half an hour or so and go to bed. So this is not required. We should take early meals about 8 o'clock, and there should be at least 3 hours before retiring, which we are able to sit down or walk down and like this. Tobacco and course should be avoided. They lower the lower esophageal sphincter pressure, therefore limit its use. Weight loss, recent weight loss, BMI more than 25 aggravates the symptoms. So don't do a rapid weight loss. Another important thing is that if we lie down, what happens that the stomach is having contents, and when we are lying down the food is here and it goes into the esophagus, and we are not awake, so we can have the nocturnal acid breakthrough symptoms which are there. So if I lie down on my left side, then uh, the stomach contents are lying in the fundus and the body, so it is not in direct continuity and it will not regurgitate. And if I'm lying on the right side, my gastric contents are here and they are going to be regurgitated and produce the symptoms. So gastric juice should be kept in the fundus and also in the body of the stomach. And it has been shown very clearly that those patients who have nocturnal symptoms and they are awakened in the night, they, if you can elevate their bad hand by 9 inches by putting 2 blocks of the EAT here, then you are at 30 degrees. Lie down on the left lateral position as has been seen. And specific, nowadays, their pillows are developed which are there. You can put your hand over here, because most of us have a habit of putting our hand beneath our head, and then only we can sleep. So this position and this type of pillow is very useful. But the cornerstone of the treatment is PPI therapy for GERD. They inhibit meal stimulated, they inhibit the meal stimulated and nocturnal acid secretion greater than H2RA, rarely renders patients achlorohydric. Not all parietal cells are blocked at a given time. Many patients think that if I block my all parietal cells here, right, the proton pump here, then I'm going to develop achlorhydria in my stomach, and more of the bacteria will develop, more of the toxins will be there, and I can develop carcinoma. But this is a misnomer. Only 70% of the parietal cells are blocked at one given time, only with one single dose. Remaining 30% continue to secrete acid. And there are new generation of the parietal cells which are replacing. As we also know that our skin is getting replaced every 5 days. So similar way, the proton pumps also get regenerated. And it is very important to understand ourselves that, and make our patients also understand that it does not produce achlorhydria. So do PPI cure reflux disease? No, they rather treat GERD in an indirect way. PPI increases gastric pH to more than 4 by decreasing acid production, and weak acid gastric contents, when they even reflux, they decrease the number of reflux episode. So PPI improves heartburn, but not number of reflux episode. And they are, if they are there, they are producing the symptoms. So we have to take the help of the drugs which can decrease the gastroesophageal reflux episodes also in some of the patients where this PPI alone is not able to control. Another very important thing which comes to our mind, that anything which is, say, आग है, अगर आग है, अगर आग है तो उस पे पानी डालो तो बुझेगा. अगर पैराइटल सेल इनएक्टिव फॉर्म में है, उनके जो प्रोटॉन पंप्स है वो एक्टिव नहीं है, वो एसिड नहीं सिक्रीट कर रहे हैं, तो पीपीआई किसको ब्लॉक करेगा? सो इफ यू हैव टू गिव्स देम ए एक्टिव moiety of these parietal cells. If they are secreting, then you can block it. Otherwise, how can you block it? So it is very important that PPI should be taken half an hour before first meal, either breakfast or when the most proton pumps are active. So we should be given that way. And second dose of this should be given half an hour before evening if the symptoms are there. So we have to take into consideration that all our patients, we give them a advice that look, every one of you has to take the drug half an hour before the meals, whether in the morning or in the night if there are night symptoms which are there. Are all PPIs safe? Probably not. Omeprazole, pantoprazole, lansoprazole, rabeprazole, 20 milligrams, all have similar ability to maintain intragastric pH. But there are always some studies which mention that within 2 hours this gives a relief, this within 1 hour it gives a relief. But yes, probably it all depends on the study to study. But all PPIs have similar ability after 24 hours or 36 hours. All have similar ability to maintain intragastric pH more than 4 hours, 4 pH 4 for 10 to 12 hours. Esomeprazole is a exception to this. It maintains the intragastric pH more than 4 for about 16 to 18 hours. All are equal in providing relief in heartburn in 1 to 3 weeks, heals erosion and ulcers in esophagus in 80% of patients in 8 weeks, and in 20% of patients in next 8 weeks with extended and higher dose of PPI which is being given to them. So probably sometimes twice a day dose has to be given. Ulcer healing has been found to be best with all PPIs. Sucralfate and H2RAs and placebos are not equivalent to this. Complete heartburn relief occurs with erosive reflux disease in about 70 to 80% of patients, but in non-erosive reflux disease, it is 50 to 60% only. So they are difficult nuts to crack. That means any patient who has got a normal endoscopy but reflux of the acid, only few of them, 50% to 60% will get symptomatic relief. Do some PPI have superior action? Yes, as mentioned, as omeprazole is superior to other PPIs, the superiority is related to higher systemic bioavailability for more than 18 hours or 16 to 18 hours as compared to PPIs. If a patient has got nocturnal symptoms and the sleep is getting disturbed, esomeprazole can be a beneficial drug to be given once in a day at before the breakfast. Do some PPI have superior action? Until recently, therapeutic efficacy among all PPIs was considered similar, but esomeprazole is superior to omeprazole, lansoprazole in healing esophagitis. And one of the trial had shown that there is some advantage which is there. So less than 5% patients who are having LA grade A and B, they respond well. But if it is patient is having erosive esophagitis C and D, more than 20% will be healing if they have not healed with the other types of PPIs. Patient with erosive esophagitis not healed with other PPIs, more than 20% will show response with the use of S-omeprazole. But one thing which comes to mind that giving 2 times the doses, is it effective, more effective than others? To overcome this particular problem, it timed released, that means pH controlled time directed delivery. Let us see here, time pH controlled and delivered delivery of the PPI can improve the 24 hours control of the acid. So it has been shown that 20 milligrams of rabeprazole or 60 milligrams of dexlansoprazole, if 30 milligrams is released in the duodenum, and it is going to control the acid in first 8 to 12 hours. Then the second one is released in the ileum or the ileocolonic junction, and it controls the next 12 hours of the. So it has been found to be very useful to control all the hours of the day and maintain the pH with the use of one single dose of rabeprazole 40 milligrams or dexlansoprazole 60 milligrams. We have a controlled and time pH controlled and time directed delivery more useful in control of the nocturnal GERD symptoms. For patients with GERD who do not have erosive esophageal or Barrett's esophagus and whose symptoms have resolved with PPI therapy, an attempt should be made to discontinue PPI or to switch to on-demand therapy in which PPI are taken only when symptoms occur, discontinue when they are relieved. So it's a important thing to understand. We should not continue. होता क्या है सब कि हर आदमी जिसने भी एक बार पीपीआई ले लिया वो ये समझता है ये तो गैस की गोली है और आपसे बिना पूछे फिजिशियन की राय लिए बिना ही वो जिंदगी भर के लिए कंटिन्यू करता रहता है। तो अगर कोई चीज आप ज्यादा उपयोग करेंगे और जब जरूरत नहीं है तब उपयोग करेंगे, जैसे जरूरत नहीं है आपने फिर भी खाना खा रहे हैं तो मोटापा बढ़ेगा। तो इसी तरह अगर आप ये दवाई खाते रहेंगे तो आपको कभी कभी नुकसान भी हो सकते हैं। जैसे आपने ब्लड प्रेशर की दवाई ज्यादा खाते रहेंगे तो ब्लड प्रेशर गिर ही जाएगा। सो इन पेशेंट विद जीआरडी who have symptomatic control and make the dose reduced to half the dose, then make it alternate day, make it twice a week, and then ask them to take it whenever their symptoms occur. But if there are many situations, they should be and they require maintenance therapy. That means as soon as you discontinue the treatment, they will start complaining of their symptoms after a week or so. So in these group of patients, they are mostly having non-erosive reflux disease or they are having erosive reflux disease with the LA grade C or D, which is severe grade. So PPI should be administered in the lowest dose that effectively controls GERD symptoms and maintain healing of the reflux esophagitis. And many a times it has been seen that you cannot make the dose half. So continue with the same doses with which the healing of the erosions have occurred or the symptomatic control has occurred. So it's a personalized, tailor-made treatment for the patients. So let us just come to a situation which is a challenging situation to all of you. What happens? I'll just narrate a case. 45 years old business executive complains since 8 months recurrent episodes of retroesternal burning and regurgitation of sour fluid in the mouth 2 to 3 times a week, mostly post meal, worsening on bending forward, gives bitter taste in the mouth, heartburn in the midnight, disturbs night sleep. It occurs 3 to 4 times per week, occurred only after heavy meal or a binge of alcohol. So take into point that heavy meal, binge of alcohol, and in the night the symptoms occur. Symptoms have aggravated in last 3 months due to odd hours of working. That means he is working late in the night till late in the night. Increase in the frequency and quantity of alcohol. General examination, he is overweight. So a patient who is overweight, the gastroesophageal junctions become uh, uh, leaky as well as the less tighter. Uh, he is a non-smoker, non-DM or non-hypertensive. Treatment, receive remiprazole twice weekly before meals. Key point here is regurgitation of acid in the mouth, retroesternal burning day or night both, causing discomfort on sleep disturbances, suggestive of change in the quality of the patient. So this is called as refractory GERD. So refractory GERD definition and incidences are different in the different guidelines. Asia Pacific Consensus defines refractory GERD as persistent and troublesome gastroesophageal reflux disease symptoms unresponsive to at least 8 weeks of standard dose of PPI. The American College of Gastroenterology says, yes, it is twice a week if you have given and still the patient is not responding, it should be called as refractory. So who becomes refractory? It has been seen that all those patients who are having non-erosive reflux disease, 40 to 50% will have refractory disease. If it is erosive esophagitis, 6 to 15%. If it is Barrett's esophagus, more than 20% are having. So there is a large burden of the disease which are refractory to PPIs. But are they really truly refractive or it is because of the some other reasons? So let us analyze all these things. Why do nocturnal symptoms of reflux occurs? With the normal PPIs, which you have taken in the morning at 8 o'clock before breakfast, in the 10 o'clock in the night or 8 o'clock to early hours of the morning, 2 or 3 o'clock in the morning, when you are deep sleep, that there is a dip in the acid, and acid becomes low, it becomes 1, pH becomes 1. So what happens that at this time, the regurgitation of the fluid occurs, which is acidic, and it awakens the patient in the reclining position. And this is the limitation of the current PPI, as I've just mentioned. They are not able to control more than 10 to 12 hours, and only 16 hours is done by esomeprazole. With the newer drugs which have come, this is a pH controlled and time controlled release of the PPI from the at 4 hours, and next at another 4 hours. They are easy to control the nocturnal acid symptoms. So there are many factors which are there. वन ऑफ द मोस्ट इंपॉर्टेंट थिंग है, आपने तो उससे कहा कि रोज खाना, उसने रोज खाई नहीं, तो कंप्लायंस इज नॉट देयर. और improvement, improper dosing, that means he's taking half the dose, or due to the half doses there is a weak acid reflux which is there, or sometimes the duodenal contents which are more alkaline, they are refluxed into the stomach and they go to the esophagus, the bile reflux occur. Or as I just mentioned, visceral hypersensitivity, delayed gastric emptying time is there. That means food lies for more than 4 hours in the stomach. Psychological comorbidities are there. Reduced PPI bioavailability is there. PPI metabolism is there. PPI resistance is there. It increases the nocturnal acid symptoms, and in some of the patients there is a eosinophilic esophagitis. But the most important thing is that if you do not take the treatment half an hour before the meals, the symptoms are likely not to be controlled. So improper dose timing is very important. Let us just see how does it happen. So night acid reflux breakthrough is defined as persistence of reduced intragastric pH below 4 more than 60 minutes time, and it is disturbing your night sleep. It is called as the refractory GERD or nocturnal acid breakthrough. And what are the consequences of nocturnal acid breakthrough and why does it occur? Let us just analyze in few minutes of time. So when you are lying down, the gastric content, when you are lying straight, the gastric contents are refluxed into the esophagus. We are not conscious, we are not having proper swallowing, because if you are swallowing in the daytime, the saliva goes and pushes it down into the stomach. Or there is a decreased salivary secretion in the night. You have not taken enough fluids, so the mouth becomes dry and you are gulping down the air. The basal pressure of upper esophageal junctions become less. Loss of gravitational effect, that means usually when we are sitting up or walking, then the stomach is upside down and there is a decrease in there. The gastric emptying also is poor, and when you are lying on the right decubitus position, it causes the symptoms. So if you have a nocturnal acid breakthrough and it disturbs your sleep, what happens? The sleep, right, is a physiological thing. So if the sleep is disturbed, it increases the GERD. If there is GERD which is not responsive, then you cause decrease in the sleep. If there is decrease in sleep, then you have whole day is wasted and you are not able to work properly and your work is affected. So sleep is the third pillar of health. First pillar is good physique. Second is good food. But the most important one is the sleep. If you are not sleeping well and you are disturbed with GERD, then you are going to have a bad quality of life and your whole work is affected. Even Obama, when he used to feel very much tired, he had a good sleep on his sofa also. So it is important that sleep is the third pillar of health, and we should understand we are a sleep deprived country. We sleep late, we do not get up early, or get up early because of the work, and in the night we are busy with our telephones, we are busy with our mobiles or TVs, and we are not able to sleep well. So this is producing bad effects. The nighttime awakening and next day your functioning is affected. You are having difficulty in falling asleep the next day. Poor sleep quality is there. Decreased quality of life is there. The supine reflex, which occurs in these group of patients because of the late evening meal, it can produce the asthma or obstructed sleep apnea, which can be there. So it's a very bad thing. But if you're not sleeping in the night, when you're driving, you have very small naps, and they can be cause of the accidents which are taking place. People say regular nap prevents the old age. Regular naps in the daytime prevent the old age, especially if you are driving, then you are more closer to your God and you are reaching there early. So accidents are prone because of these nocturnal sleep disturbances. You only are not suffering, even your spouse also, who gets up when you get up, her sleep is disturbed. And this thing has been seen in one of the studies. 27% reported that their heartburn induced sleep disturbances and kept their spouse from having good night's sleep. And this is very important, that you should treat nocturnal acid breakthrough. So diagnosis has to be seen. I'll not go into details of this, but only one thing I'll say, that if your endoscopy is showing normal symptoms or normal uh, glucosa, then they should be offered a pH monitoring of the with the wireless pH capsules, that should try to find out whether there is a normal acid exposure or abnormal acid exposure. You are having a motility disorder, or you have functional heartburn, or you have a hypersensitivity of the esophagus. So this can be decided with this therapy. And the treatment paradigm has been changing in these group of patients, and it is essential that we should uh, adherence of the treatment should be seen. Timing of PPI injection should be assessed. Assess true refractory PI and exclude the functional heartburn and hypersensitive esophagus and eosinophilic esophagitis, which can also mimic the refractory GERD. So non-adherence has been seen that only 53% of patients filled their monthly PPI description, and more than 80% times. That means they do not go to the for the getting the drugs many of times because of the financial constraints, or because of the lack of the time, or due to other reasons. Only 55% of patients took PPI once daily for 4 weeks as prescribed. 37% taking for 12 or fewer days out of 1 month. So non-compliance or non-adherence is there. Non-compliance is also there. Appropriate time the patient does not take, and many a times we as physicians do not give instruction to the patient. One of the study revealed that 46% of the patient dose PPI at inappropriate at appropriate time. The 64% did not do it. 36% of physicians do not give any direction or give inappropriate direction to the patient. So it is our duty as physicians to tell our patients that it should be taken half an hour before breakfast or half an hour before the night meal, and not at any other time. So this study shows that 70% of the primary care physicians and 20% of the gastroenterologists did not give a patient clear instruction about this. So this is refractory disease. So for refractory disease, we can give twice a day doses of the same PPI. It's very effective. But giving double dose of PPI is very effective. And if you can use the time released or pH dependent release of the ribuprazole or dexlansoprazole, that they can control the nocturnal acid breakthrough. But another thing which is coming into understanding by research is that after the night meal, what happens, that there is a food which is over here, then the acid is coming or floats on the surface of the food. So this becomes a acid pocket. And when you lie down, this whole acid regurgitates into the esophagus and lower esophageal sphincter in the night becomes little lax, or patient has got hiatus hernia, then this acid gets reflux and this produces symptoms. So how can we control it? So one is antacids, but antacids can only decrease the pH of the stomach content. But this acid pocket cannot be taken into control. So what is done is that you give the uh, drugs which are reducing the acid by antacids, which can be given. And another thing is alginic acid, which is a uh, which is making a foam or a raft of the foam on the surface of this acid, right? So this whole becomes a foam, and when you lie down, this foam goes up, and not the acid. So acid pocket, this pH which is low here, this acid does not go into the esophagus. So alginic acid has been found out. It's a old drug, but used in a new packet, and this has been found to be very useful. So 2 teaspoonful of alginic acid containing the antacid can be given in the night, and that's very useful. So when you give a nocturnal dose, right, it makes a foam over the surface of the acid, and its acid is not getting reflex. Only this foam is going into the esophagus, and the symptoms are controlled, and it has been found to be very useful. Giving nighttime of the ranitidine or H2RA, it has got limited use. It is effective for few days, then it becomes non-responsive. It has been shown in a trial that all those patients who have refractory heartburn, if you exclude all those patients having functional heartburn, or they are having what we call as esophageal hypersensitivity, then this randomized trial shows that medical versus surgical treatment, surgery is better in controlling this thing. And it has been shown that 60% of the patient with the anti-reflux surgery, right, you have the fundoplication over here, and this is very useful. But when they tried to exclude the patients of various diseases, they included 366 patients. They could only recruit 78% with the true reflux. If you do not have true reflux, then it is not true refractory heartburn. So they will not respond very well. If you have true refractory disease, by excluding the by various tests that other causes are not there of refractoriness, then it is going to be very useful. So our aim of today's discussion is that there is a volcano, that the acid is going to be refluxed into esophagus and produce symptoms. Night awakening is there. We have to give a in the Japanese there is a Fuji पर्वत है एक ऊपर जहाँ पर बर्फ जमी रहती है, right? This is a very very famous place, and we should give a calmness to the patient. We may not control what we can do, the control of the disease, but we cannot completely eliminate the disease. So our aim should be giving the symptomatic relief to the patient as far as possible by lifestyle management, by drugs, and by using alginic acid in nocturnal acid breakthrough patient. Thank you very much for your uh, giving me time. I'm ready for any suggestions or any questions.
Yeah, thank you so much, sir, for first of all giving your precious time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, I can see, sir, we have received few questions from the participant, and if you allow, can I take this question with all your
Sure,
permission?
sure, sure, sure.
Yeah, sir. First question is, what are the indication for foodopilication in the treatment of GERD?
I just mentioned in the last slide. Let me just come back to this particular thing. As I just mentioned, fundoplication is very useful. It will be only successful in those situations where you have been able to exclude, right, the various other things. That means esophageal hypersensitivity, eosinophilic esophagitis, functional heartburn with the manometry. That is, there is a special type of manometry which has come, which decides that the acid reflux which is coming is producing symptoms, and symptom correlation is there. They are the true refractory patients. So in these group of patients, out of 366, they had to exclude these many number of patients. They could only randomize 78% of patients, and in these 78% of patients, it was very, very effective as compared to the medical treatment, right? So controlled medical treatment, when they were given even the baclofen and omeprazole, this was not very effective in controlling. So 50% improvement in the health related quality of life was produced with anti-reflux surgery, that means fundoplication. Thank you.
Okay, sir. Thank you so much for explaining it really well, sir. I can see there is one last question for today's session. The question is, how is GERD treated in young patients?
Young patients need quite a lot of attention because they have to live a very long life. That means another 50, 60 years that they have to live with this disease. So all those patients where we can find that the gastroesophageal reflux disease, they are dependent on the PPI, and sometimes there is always a fear in the mind that do PPIs produce harm, though the longitudinal studies done for more than 5 years have shown that it usually does not cause any side effects or bone injury or bone fractures or mental changes or a carcinoma of the stomach. All these are not seen in long term use, but he has to live with this. So if he agrees to take one pill a day and keep his life very good, it is there. But other group of patients, nowadays we are having lot many endoscopic procedures which are there. What is done in the endoscopic procedure there, that uh, there is a wire which is connected to radio frequency, and there are knobs which are there. At the G junction this is placed, and radio frequency ablation is being done there. And with the radio frequency ablation, the G junction becomes tighter and the reflex symptoms decrease. But this is also not 100%. Second is, we can do a fundoplication through the endoscope also. Nowadays we have endocinch machine which is there, by which we can do it. Or we can, what we call is that we can burn the G junction is a stomach below this Z junction. We can burn that area, and that makes it tight. But fundoplication is one of the best technique for these group of patients, and it has been found that if you exclude other causes, then he is going to have at least 68 to 78% relief in his symptoms. Others will not be treated completely. So long standing time is there in a young person. We should try to give PPIs if they agree to it. If they don't agree, we can offer them surgery or endoscopic fundoplication, or endoscopic suturing can be done.
Okay, thank you so much, sir. You have explained really well, sir. I hope that those who have asked the question has received his answer, sir. As I can see, there is no more question from the participant end. With all your permission, shall we conclude this session, sir?
Thank you very much. Thank you very
Thank you
much
so
for
much, sir.
inviting.
And yeah, sir. And hope to see you again with different topics, sir. And take care of yourself. And it was a really pleasure to have you here, sir. Bye, sir. Thank you.